cord is, I'm going to go in there with my 2 fingers until, okay, there's my umbilical cord. I'm gonna go in there and push baby's head off of the umbilical cord until my heart tones come back up. Once you insert your sterile fingers in there, take baby's presenting part off of the umbilical cord. You are to stay in that position until this baby is delivered by C-section. Okay?
The nurse stays like that?
The nurse will stay on the bed while we roll the patient back, and your hand will stay in that vagina until that baby is delivered. No.
Yeah. I don't think this one's okay for kids to watch.
One of our nurses on
Where do you work?
6 months ago. So she was on there and she was there the whole time until baby was delivered.
Oh, at press?
Yeah.
Do you work nights?
Yes. So the first thing you should do is call for assistance immediately. You will never leave the client. Notify the provider. Have someone notify the provider. Some rooms have a staff assist, so if you need more staff in there, press your staff assist. Do not press your code blue. It's not someone coding. You're going to get people that have nothing to do with labor and delivery. You're going to use a sterile gloved hand, insert your 2 fingers, and take the presented part, whatever the presented part, if it's like a foot, if it's a hand, whatever. Whatever presented part you feel is on that umbilical cord, you're going to lift away from it. You can reposition them in Anita chest or Trendelenburg, but as long as if someone's in there and taking the presented part off the umbilical cord, as long as baby's heart rate goes back up, we're good. If baby's heart rate still isn't going up, you can try those different maneuvers or we're rushing back into a C-section. I tried, HI says, apply a warm sterile saline. No, we don't do that. We just rush back, okay? But HI purposes, you want to apply a warm sterile saline soap towel over the umbilical cord.
Would that be like a cause of position change, like flip them on their hands and their knees to that type of thing? Or is it kind of just, you leave it as it is and?
Just kind of leave it as it is. You can, I mean, when you have a prolapsed umbilical cord, you won't want them on hands and knees because you can't monitor baby that way.
Okay.
So we can put them in Trendelenburg and see if we can get baby to kind of help gravity help us and get, baby maybe to come off of it that way.
Okay.
Is this something we call to have a C-section ready? When we see this pop out, like how you did for the other things?
Yeah, so it will be an automatic C-section most of the time.
So we have them all ready once we see, like, is that?
You have someone call the provider and someone call anesthesia, so just make sure they're both called. And then also, if you have a NICU available, have NICU there as well. And then at that point, we can administer fluids, we can give mom oxygen to help keep baby oxygenated. Just hopefully we can just keep baby off that cord long enough until baby's delivered, and usually babies will come out just fine. Now, all of a sudden, if you're not feeling a cord and something's going down and you're doing several position changes, then we'll rush back no matter if you can't feel a cord or anything. Just once you feel the cord, you do not take your fingers out of that vagina. They stay in until baby's delivered, so that's just one thing to remember.
And that's the first thing you do.
Call for help.
Yeah, so first thing,
Well, yeah,
usually you'll have your partners just say, hey, call the provider, especially when you see a decel, you always call your provider and let them know, and they'll rush. If they're not already on the floor, they're coming from their call room or whatever. So there's a picture of kind of what it looks like. It could be protruding from the vagina. Again, it could be kind of still inside. So unless you're feeling it, you'll kind of feel it pulsating, and then just find the presenting part and lift baby off of it. Meconium stain amniotic fluid. So this is meconium passage in the amniotic fluid during the antepartum period prior to the start of labor, and is typically not associated with an unfavorable fetal outcome. So again, when the bag of water breaks, or if we go in there and break it artificially with that hook, we always monitor the color of it. So if you do notice, usually it's going to be, it could be like a dark green color or yellow or any kind of color that just seems off, but usually it's going to be green. Then you want to note the consistency too. There's been meconium fluid where it's like super thick, what we call like thick mech, almost like a soft stool, basically expelling from the vagina. And then, or sometimes it's like very light, so there may have been a bowel movement. It just means that baby has made a bowel movement in utero. So if you do notice that, then you want to call the pediatrician and let them know that there's meconium fluid, and that you'll call them for once we're ready for delivery, because we always want to have the provider there. We're gonna call, if you have a NICU team, call NICU to be present at delivery in case baby doesn't want to breathe. We can resuscitate as needed. So if you have meconium, amniotic fluid, have your resuscitation stuff out and ready to go, okay?
Why would meconium cause them to not want to breathe?
So we don't want them
Inhale
to
it.
swallow it, so, yeah, so if they aspirate on it, so they could aspirate and then, it'd be infected, but that also cause, trouble breathing at that point. We always try and suction them before they cry.
Right.
Sometimes it's hard because they come out crying,
Right.
but we try and suction, we can still do skin to skin. I think when I delivered my, first baby, it was at Loveless Women, they would take the baby right away with meconium. I don't know if they still do that. They would take the baby right away, and suction them before they cry. So I remember that was like the longest minute of my life, not hearing my own baby cry. But that's what they would do, deep suction really quick to make sure none of that got into the lungs. But typically now they'll do skin to skin. We can suction, so always do mouth to nose with a suction bowl. Remember that, you may see it on a CMS. So mouth to nose. So we suction, deep suction, can kind of go back there and get all of that gunk out before they start crying. And you can get in the nose too. If you notice that they're breathing really fast or they're kind of gasping, then we're gonna take baby off of mom right away and just go take them to the warmer. We're gonna put an O2 set on them, make sure we have a heart rate of over 100 on baby. And then if we have to do any kind of resuscitation at that point, we'll go from there. But typically we can suction them, as long as we can suction them before they take their first breath, then they're usually pretty good. But for whatever reason, if they're having some difficulty breathing, we may have to, what we call transition them. They may have to be put on CPAP. They'll get an x-ray to see if they have any kind of infection or blood cultures, if they have an infection, if they did aspirate it at any point.
My oldest did the same thing, and I don't think that they got it all out, and then they gave her back to me, and I'm like, something's not right here.
Yeah.
And then they took her away.
Yeah, so those will continue to monitor. Most of the time they do okay, but then you'll see during the recovery period if the baby is having any kind of gasping or if they're tachypnics or they're breathing really fast, then we'll just monitor them more closely. So usually if it's on the nursery, then maybe they'll have to go to NICU for a little bit.
Do you guys suction over there? Cause they were saying they don't suction no more.
They said that they try to avoid it because whenever you go to get them to breastfeed, they'll be like, no, I don't want that, because the last thing they have in their mouth is getting shut down their throat and shut down. That's what they said.
Yeah, no. So usually you wanna just suction them, especially if they sound wet, sometimes, or sound wet, especially after delivery, no matter what, if it's meconium, we definitely need to suction them, because there's still, they could have, they always swallow fluid or have fluid in their mouth when they're being delivered, whether it's vaginally or by C-section. So always wanna suction. Usually if we can have them cried out, usually if we get them crying a lot, they can get that out naturally. When it's meconium, definitely suction with a bowl syringe. If it's just normal, they can try, they may not have to use it if baby's already, you
That's
know.
what she was saying.
That's
Yeah.
what we're asking, yeah.
Yeah, if baby's, you don't have to, yeah, if baby's like, then we're fine.
Oh,
And then
okay.
you take a listen, if baby sounds wet in the lungs, then you may want to suction or deep suction if needed. But
Okay,
usually
that's
if
what
it's
we're
normal, yeah. Also, we can deep suction, so if we need to deep suction them, we'll just take a suction catheter and suck all that stuff, as much stuff as we can, before we give them back to mom. But usually, with meconium, you may not see, a difference in the fetal heart rate at all. On the monitor, you may see if baby becomes minimal variability, it may be, caused to meconium. But for a reason, if you have, your baby just doesn't look good, and we know there's meconium and we have to take them back for a C-section, we still have, everyone there as standby, during this delivery. Fetal distress, so this is when a fetal heart rate is, above 160 or below 110 beats per minute. If there's a fetal heart rate shows decrease or no variability, whatsoever, so you have that minimal variability and you're doing all your maneuvering, turning patient, giving a bolus, giving oxygen, turn Pitocin off and baby's still having either minimal variability or having those D cells, then we'll call it and take a patient back for a C-section. Dystocia just means prolonged difficult labor. Risk factors is gonna be fetal macrosomia, maternal fatigue, uterine abnormalities, cephalopelvic disproportion, fetal malpresentation. So if there's like a shoulder dystocia, anything like that. Usually the sign is gonna be insufficient progress to dilation, effacement and fetal descent during labor. So what I said last week and kind of touch base on, if there's cervical change that hasn't changed, if a cervix hasn't changed in the last 6 hours and she's contracting every 2 minutes for the past 2 hours, but just not making any change, or you're on a high dose enough of Pitocin that you can't go up anymore. If there's no change within 6 hours, they'll call for a C-section. Just because they should be making change, especially if they're in active labor, at least 1 centimeter an hour or 2. Let's see, so just to make sure, so just remember, persistent occiput posterior position prolongs labor. So what position is baby in?
Posterior what?
Occiput posterior position. So what is baby looking up or looking down?
Oh,
Baby's looking up. So remember last week I told you if baby's in that posterior occiput position, if baby is sunny side up, so where is the patient feeling their pain?
In their back.
In their back. So what are we gonna do if they're feeling pain in their back?
We're gonna turn them.
No, you're
So
gonna put,
sacral counter pressure. And then if we're assuming that baby may be in that position, then position changes. So we can go hands and knees. We can definitely try that to see if baby will turn that way. We can try that peanut ball I told you guys to see if we can try and turn baby. So during those contractions, baby's able to kind of turn. Or during pushing, that could prolong or have that dysfunctional labor if their baby is in that funky position, just because it just prolongs labor. It's possible to deliver baby sunny side up, just takes longer. Okay?
and they bruise a lot, don't they?
Yeah, they'll get, their face will be pretty bruised, and then they'll have like, almost like what they call unicorn horn. They may have some fluid accumulated there. Dysfunctional labor, so these could be, if our patient isn't making any kind of cervical change, or if she go up on the Pitocin and still not making the cervical change, we can do internal monitors. So that's when we can do that IUPC or that fetal electrode on baby's head, to know exactly how baby's doing, with these contractions, how strong are these contractions. The only way for us to know how strong these contractions are is with the internal monitor, that IUPC, okay? And then again, with a dysfunctional, we may, at the point if heart tones are down, we may have to do like vacuum assisted, or forceps assisted delivery. We may have to do an episiotomy, to get baby out, and then emergency, any kind of emergency situation, we run back for a C-section. So just a picture of contractions here. So our hypotonic, so not contracting very much. So near the top, our hypertonic is going to be almost like our tachysystole. So more than 5 contractions in a 10-minute period. Precipitous labor. So this is labor lasting less than 3 hours from onset of contraction to the time of delivery. So risk factors, so those that may have hypertensive disorders, they're on oxytocin, a younger maternal age, preterm deliveries, a lower infant birth weight, or a placental abruption. So usually the signs of a fast labor is abrupt onset of intense contractions. Complications, there can be maternal lacerations, tissue trauma, uterine rupture, postpartum hemorrhage, fetal hypoxia, or a fetal intracranial hemorrhage. As a nurse, we encourage them to remain in a sideline position. We need to administer oxygen or an IV bolus, or we need to discontinue the Pitocin or oxytocin. We'll go ahead and do that. and then assist with delivery. Again, there are, for some of this labors where our patient was 3 centimeters, and all of a sudden she's about to push out a baby, baby's crowning within an hour or 30 minutes. It's happened. I've delivered 2 babies. Nurses, we can deliver babies, but we don't want to. We always want to call the provider, but sometimes it's out of our control on how fast this labor progresses, especially if our provider isn't on the floor. Especially during the nights, they may not be on the floor. They're probably in their call room because they've been working the clinic all day. So usually we'll call them, hey, she's about to deliver, or someone's calling them right away, and they may like take a step in the room and we already delivered. So the one thing to just remember, if you're having a patient and she's crowning, you should have a table set up for a delivery already. If you wanna go ahead and glove up, you'll take a sterile towel and you can actually just put, so if baby's head is crowding out of the vagina, you want them to go slow. So what I highlighted here is important because it's gonna be on your exam. So to control a rapid delivery, you want to apply light pressure to the perineal area and the fetal head. So if the head is there and we're waiting for the provider, just kind of place a sterile towel there and just add a little bit of light pressure so that head isn't just being expelled out right away. We want to go slow to prevent lacerations, prevent hematomas, or anything with baby, any complications. But once, once the head's coming, sometimes you just tell them not to push, just pant through your contractions. But sometimes the body just naturally does its thing and delivers the baby and the patient isn't even pushing. So just add that light pressure just to control the delivery. And then usually if labors happen that fast, usually it's like their 2nd or 3rd baby. So you usually if we have to deliver them, it's really fast. I think we had one time a nurse had a shoulder dystocia and the provider wasn't there. So it can be in scary situation, so that's why we really urge providers to be present and keep them updated as much as possible. So, keep them up all night if you want, but just keep them updated. Hey, she's getting really uncomfortable, and this is her 3rd baby, 4th baby, and she's moaning a lot. So usually if they hear that, they're like, okay, this is probably gonna be fast. Yeah. But that's gonna be the most important thing to just remember. Just applying light pressure to the perineal area for that head to gently expel. We kind of went through the uterine rupture, so it can be an incomplete or complete rupture of the uterine wall, a peritoneal cavity, or the broad ligament. Risk factors: hyperstimulation from oxytocin, overdistension uterus, or previous uterine surgery. So that's going to be your previous C-sections, especially if they're doing a VBAC or a TOLAC. So if they're having that incisional pain, especially if they're previous C-section, that's going to be the first thing you should be going. Symptoms: they are going to have sharp abdominal pain, so that's going to be something to remember. If there's a uterine rupture, it's going to be sharp abdominal pain, so they're screaming, and they're going to tell you it feels like something is tearing inside me most of the time. Complications: this could lead to maternal hemorrhage, fetal hypoxia, maternal or fetal death, and a possible hysterectomy. So just be cautious, especially if you notice any bleeding or if you notice anything on the heart rate of baby. If baby's heart rate's going down and you can't bring it back up, if mom's becoming hypotensive, whatever's going on, usually by the time, hopefully we can catch this and deliver baby and mom's okay. Sometimes this could happen at home, and unfortunately it happened one time with a patient that came in with us. They came in and she was already bleeding out. By the time we got to baby had already passed. Anaphylactoid syndrome in pregnancy, so that amniotic fluid embolism. I know this is one of your guys' presentations, whoever group this belongs to. So this is amniotic fluid that infiltrates maternal circulation and obstructs pulmonary vessels. Risk factors could be advanced maternal age, diabetes, eclampsia, multiparity, uterine rupture, meconium stained amniotic fluid. Signs and symptoms: usually it's just going to be a sudden chest pain, difficulty breathing, tachycardia, bleeding, and hypotension. Complications: this leads to respiratory distress, circulatory collapse. The patient can go into DIC. So the amniotic fluid has increased the thromboplastin, which causes the increased clotting. So again, indications of respiratory distress, if your patient becomes restlessness, cyanotic, dyspnea, pulmonary edema, or they go into respiratory arrest. Coagulation failure, so if they're bleeding from any of the incisions, those venipuncture sites, petechiae or ecchymosis, uterine atony, so that means that uterus is not clamping down or not contracting. And then we have indications of circulatory collapse, so they become tachycardic, hypotensive, they go in shock, hypovolemic shock, and they may go into cardiac arrest. So early signs and symptoms of amniotic fluid embolism, increased anxiety, an impending sense of doom. If you ever have a mom that says, I think I'm gonna die, take it literally. You should always, if a patient ever tells you that, take that literally and watch them like a hawk, because they have some type of sixth sense with this thing, and sometimes, you know, they're right. Agitation, confusion, nausea, vomiting, chills, skin discoloration are gonna be your early signs. As nurses, we're going to administer oxygen via masks, 8 to 10 liters, assist with intubation, any kind of mechanical ventilation, and CPR. So we're calling a code. If they end up in respiratory distress, you're just going to call code, get as much help as possible, and then once we can stabilize enough, they'll just be shipped off to ICU, intubated, and then hopefully gets better. This doesn't happen very often. I think I had one patient said that she was so scared she was going to have an amniotic fluid embolism, and how rare is it? So it's very rare. You don't see it happen. How it happens, it's just kind of like a freaky thing that happens, but it doesn't happen very often. I don't know the percentage, but since I've been in labor delivery, or at least those that we have had, those that have worked at the facility, they haven't had one of these happen, but they happen. So just be aware that this is something that can happen. Any questions on any of that information? No. Okay. Then you're going to discuss on the topic. If you guys are splitting it up, put some notes on your PowerPoint, so then I can go through and read it as if you were presenting, just so I know you guys understood the material. The PowerPoint should not be more than 10 slides ultimately, so everyone should at least do 1 or 2 slides.
What's the minimum?
10. 10 and 10.
Do 10 slides.
You can go between 10 and 15. It shouldn't be a lot. What else I want? Okay, so when it comes to preparing for you guys' CMS, so I just heard my NCLEX coach has stepped down for OB, so Miss Sandy was gonna do it, but she's no longer gonna be able to do that, so I will let you know if I have an NCLEX coach for OB, especially those that need a little bit of help when it comes to the CMS. To kind of go over topics and stuff. So I'll let you know if I find another NCLEX coach so you guys can work with if you guys can't meet with my schedule. I was hoping to have her because my schedule is so busy as it is. So worst case scenario, I think what I'll do is I'll do like a Zoom meeting. It will be I'll just basically be doing like a review of everything, or kind of what to touch on, what I think is gonna be important. So we'll do like a little review, and I'll do that on Zoom, and I'll just record it. But you guys are more than welcome to log in whatever day I decide to do it, and I'll do it like a week before for CMS. So I'll let you know, and hopefully that will help until I can figure out who the next NCLEX coach is. You need someone to at least go to, especially because I don't have a lot of like openings when it comes to the CMS. So hopefully, we can do maybe like a review day in class, and then we'll do another review, an optional review. I'll record it, and then you guys, hopefully that will help you guys. What else do I want to discuss? Okay, so I'll post the new slides, the more visual slides. I'll post that into Canvas in your announcements. So just look at your announcements. If I add anything, I'll just put everything in announcements. So You can use that as studying. And then also when it comes to your guys' study guides, again, just wait until we go over the information first. Or if you wanna go ahead, if you have any questions, especially when it's regarding the study guide, if you haven't gone over it yet, just wait until the class, and then we'll do a review, hopefully next week. I think next week we're only touching on postpartum. We're not going through the complications, so it's gonna be very basic. We should be able to, at least the first hour, go through that information, and then we'll do like a review again. Did you guys like Jeopardy, or you wanna do something different? Okay, so I'll create a Jeopardy game, so we'll do that next week, and then, just let me know what questions you guys have, with anything that's gonna be on the exam. I think I prepared you guys well enough for that. I'll go over next week too, over the, I think there's 2 bow tie. I don't remember what's on the second guide, but there's 2 bow tie questions and a matrix question, so, I'll look over that and see where I can help you, but you guys should know enough information to, figure out that, information and to answer that bow tie and the matrix. Any questions? Concerns? Okay, if you need to set up a meeting with me, let me know, see me after class. But otherwise, just email me and I will see you all next week.